My sincere thanks to Inazir and Professor Ajay Duseja for giving me this opportunity. I've been given this job to talk about the advances in management of autoimmune hepatitis, and over the next 15 minutes, I'll take you through what is new in treatment of autoimmune hepatitis. We all know that it's a T cell mediated disease and it's a heterogeneous disease, can manifest in early childhood, but can also manifest late in 7th and 8th decade of life for the first time. Now, this disease is characterized by hypergammaglobulinemia, certain autoantibodies, and you have certain HLA antigens, a typical histology, and one of the criteria which we use in clinical practice is an appropriate response to immunosuppression. Now, this is the first line treatment for autoimmune hepatitis, and these are the ASLD guidelines, which recommend that you can use steroids and azathioprine depending on the manifestations of the disease. In chronic hepatitis, a combination of steroid plus azathioprine. In patients with cirrhosis, you can use steroids. Azathioprine cannot be given in patients with decomp cirrhosis. And in acute severe AIH, it's been suggested that you can also use intravenous steroids. The guidelines are same by EASL also. So, what are the endpoints of treatment when we are looking at autoimmune hepatitis? So, first is we try to see the response at 4 weeks, and if you have a 50% decrease in AST/ALT, if there is less than 50% decrease in AST/ALT at 4 weeks, we say it's non-response. Complete biochemical response is defined as ALT, which is normal, and IgG, which is normal at 6 months, and insufficient response if it is not normal at 6 months. Histological response is when the HAI is less than 4, and we usually monitor these patients closely. 6 months is complete biochemical response. Biopsy response is usually seen at 2 to 3 years. Now, with the first line drugs, remission is possible in around 65% of the patients. Incomplete response is seen in around 15%, treatment failure in around 10%, and drug toxicity in around 15%. And if treatment is stopped, majority will relapse. So, stopping rules are very difficult in patients with autoimmune liver disease. Now, my primary focus today is going to be how do you treat difficult to treat AIH, that is the treatment intolerant group, and patients who have insufficient response and non-responders. So, these are the second and third line drugs which are available with us. Calcineurin inhibitors including tacrolimus and cyclosporin. Mycophenolate mofetil, we have some interesting studies on this. mTOR inhibitors, sirolimus and everolimus, and some data on 6-mercaptopurine, methotrexate, and thioguanine. I'm going to discuss this one by one, and then in the end I will show you what are the evolving drugs for AIH. So this is a big study by Kumali, and they included 2,200 patients with autoimmune hepatitis. Second line treatment was given in 302 patients, MMF in 121, and tacrolimus in 80%. Let's look at the response. Indication for treatment was ASA intolerance in 38%. So around 40% will be ASA intolerant, and non-response to treatment is seen in around 46% in the study. The complete response was seen in around 70% of the patients, and obviously the response was better in patients who were intolerant, both in MMF and the tacrolimus group, as compared to patients who had insufficient response or no response to treatment. Now, this is a recent paper from the Swiss group, 144 patients. 35% patients had received MMF in this study, and 80% received MMF due to first-line drug intolerance, either it was steroid or azathioprine, and 20% due to insufficient response. Again, the remission rate with MMF was pretty good, 81% versus 30, and they also showed that additional doses of prednisolone is required if there is an insufficient response to treatment. And probability of activity is very low if you treat them, and if there is insufficient response, it is higher, whereas if they are intolerant, the response to histological activity and biochemical activity is much better. Now, let me focus on this recent studies. This is not for second line, this is for treatment naive patients. A very interesting paper, a first randomized trial after around 10-20 years in autoimmune hepatitis. This study was done in 13 centers in Netherlands and Belgium, included 70 patients with a diagnosis of AIH, randomized trial, open label, and median age was 57 years, predominant female population. So they started with prednisolone for 4 weeks and added either azathioprine in one group, and in the second group it was mycophenolate mofetil. The primary outcome was percentage of patients with normalization of ALT and IgG after 24 weeks of treatment. Now let's look at the response. 56% in the MMF group as compared to 29%. This is actually quite low when we look at the response to azathioprine in other studies. The secondary outcomes were side effects. Azathioprine had more side effects as compared to MMF, and cessation of treatment due to side effects was more with azathioprine, 25 versus 5%. But then there are caveats to this study. What is the good part about this study? It's a randomized control trial after many years, something new in autoimmune hepatitis. MMF has been shown to be better in this study and the better side effect profile with MMF. But what are the caveats? Obviously, the cost of MMF is higher than azathioprine. You can't use this drug in patients who are wishing to conceive. In the post-transplant setting, it has been seen that MMF causes a lot of GI intolerance. Probably that is early on, but then in this study, they didn't see any side effects with MMF. The other caveat is MMF has to be given twice a day, whereas azathioprine is given once a day. And in this study, the response to azathioprine was much lower as compared to what all previous data we have. So I think we need more studies on this, and maybe this drug might become the first-line drug in the future. Now let's look at the calcineurin inhibitors. I'm just going to show you this meta-analysis. 20 studies, 279 patients, response rate 53% in patients with insufficient response, and who were intolerant, it was around 67. So similar to mycophenolate mofetil. Remission rates were around 50% when it's used as a second-line drug. The response rate comes down when it is used as a third-line drug. So if it is being used as a third-line drug, response is around 25%. Now, there's some data on mTOR inhibitors. These are old studies, nothing new. 7 patients data, around 30-40% response. And this is on sirolimus. Again, 2014, this study was published. 5 patients only, response rate around 50%. So, no robust data on the use of mTOR inhibitors in patients with AIH, no recent data as such. Now, let's look at the evolving drugs. What is there for us in future? Rituximab. This is a monoclonal antibody against CD20, resulting in B cell depletion. You have B cell activating factor inhibitors, belimumab. This is again a monoclonal antibody against BAFF or BAFF receptors, which inhibit B cell differentiation. And you have some data on interleukin-2 proteasome inhibitors, and these are on all drugs which are being tried in clinical trials so far. So let me show you this interesting study and interesting data on rituximab. Now, this is the study by the International Autoimmune Hepatitis Group. 22 patients were included in the study, all with type 1 autoimmune hepatitis, age 40 years, and predominant female population. Now, the first-line drugs which were used in these patients and the second-line drugs which were used was prednisolone, azathioprine, MMF, and tacrolimus. And once there was failure of these drugs, they were given rituximab. The 2 doses were given in these patients 2 weeks apart. And let's look at the response. Pretty good response. AST, ALT, and immunoglobulins settled. Not only these enzymes settled, but this response was maintained at 2 years of time. Now, this was also seen that there were freedom from flare-up, which was seen in around 91% at 1 year and 71% at 2 years. So, flare-free period was also pretty good. So, this result looks encouraging. And let me show you this recent data. Big study has come up in Liver International recently. A multicentric study of 35 patients now, female patient again predominant, 10 patients had cirrhosis, that is 30% had cirrhosis in this study, and 12% had variant forms of AIH, that is overlap syndrome. And what were the indications of rituximab in this study? 40% refractory AIH, 54% concomitant autoimmune or hematological disorders, 6% were intolerant to prior treatment. Now let's see the response. 89% had complete biochemical remission in this study, and reduction or discontinuation of immunosuppressant was seen in 97%. This is the overall result. 50% of the patient withdrew one immunosuppressant, and the dose of prednisolone came down from 20 to 5, in most of the patients. Now, let's look at the second group, refractory AIH, which is obviously difficult to treat. In this also, the response rate was pretty good. 86% had complete response and 100% had reduction in the second immunosuppressive or the third immunosuppressive drug. Not only this, flare-free rate at first, second and third year was 86%, 73 and 62%, which is pretty impressive, and I think this would be the future drug which can be tried in patients with refractory AIH and maybe in patients with acute severe AIH who do not respond to the conventional steroid therapy. Now let's look at the other drug which is available. This is belimumab, and it has been tried in patients with autoimmune hepatitis and primary biliary cholangitis. Now this is a new drug. This is a BAFF inhibitor. B cells are involved in activation of the T cells, and they act as antigen presenting cells, and this drug will inhibit that and prevent the activation of T cells. Now some very encouraging data on this drug also. Refractory AIH patients, 6 patients, 3 patients had concomitant Sjogren disease, and all of them had elevated levels of B cell activating factor. In all 3 patients with AIH, belimumab improved disease control, and it reduced the problematic side effects from corticosteroids and calcineurin inhibitors. You were able to reduce the dose of other immunosuppressive drugs. Not only this, the concomitant Sjogren syndrome also improved and appears to be a promising treatment option in patients with autoimmune hepatitis. So let me summarize here. We know that autoimmune hepatitis is a complex and heterogeneous disease. Our knowledge of the mechanisms of autoimmunity has increased exponentially in recent years. The ultimate goals of developing new treatments for autoimmune liver disease are to minimize tissue injury, improve the quality of life, and increase the life expectancy. Response to first and second line drugs is reasonable. It's not excellent, I would say. Biological agents may satisfy an unmet clinical need for treatment of difficult cases. We know that biologicals have taken over for treatment of other autoimmune diseases. We have good data in IBD, we have good data in SLE, rheumatoid arthritis also. The unmet need in autoimmune hepatitis might be met with these 2 drugs which I have shown, rituximab and BAFF inhibitor. Finally, monoclonal antibody CD20 drugs results in rituximab and BAFF inhibitor appears to be promising, but definitely we need more data on these 2 drugs before we can recommend in our clinical practice. Thank you very much. I will stop here.